Hello, thank you for visiting this presentation. Let's take a look at the types and imaging findings of premalignant lesions of cholangiocarcinoma. Premalignant lesions of cholangiocarcinoma include one microscopic lesion, which is biliary intraepithelial neoplasia, and three macroscopic lesions, which are mucinous cystic neoplasm, intraductal papillary neoplasm, and intraductal tubulopapillary neoplasms. Biliary intraepithelial neoplasia, BILIN, is characterized by flat or micropapillary growth of atypical biliary epithelium. It has been previously called atypical biliary epithelia or biliary dysplasia. It occurs in the presence of chronic inflammation of various causes such as hepatolithiasis, biliary cysts, parasitic disease, and primary sclerosing cholangitis. Because of its small size, the lesion itself cannot be seen on imaging exams, but changes such as stricture related to underlying disease can be observed. In this patient, BILIN was found with segmental duct dilation, focal stenosis, and hepatic parenchymal atrophy of the involved segment on imaging exam. In pathological exam, intraductal stone disease and low-grade BILIN was diagnosed. Stone debris are observed in the duct on the pathology slide of another part of the patient in the previous slide. When the area around it was magnified, the dysplastic change is well observed in the bile duct epithelium of the surrounding duct. This pathologically diagnosed BILIN2 lesion was accompanied by hepatolithiasis. In MRCP, bile duct stenosis and peripheral duct dilations are observed. In other ducts, decreased bile duct branching and arrowhead sign are noted, suggesting chronic cholangitis. In the thin slide coronal and axial T2-weighted images, stones are well observed in the duct. In the pathological specimen, IHD stone and thickening of surrounding ducts are noted. In this case of BILIN3, focal stenosis and upstream duct dilation of the bile duct are observed. IHD stone was not found, but was associated with chronic calculous cholecystitis. In this case, duct stenosis or proximal duct dilation was not remarkable. The grade of BILIN and the degree of stenosis or dilation of the duct do not seem to correlate with each other. In this patient with a history of treatment for CBD stone 8 years ago, narrowing and wall thickening of hilar ducts was suspected as hilar cholangiocarcinoma. On surgery, BILIN3, high-grade BILIN, was diagnosed. The fact that it shows a long segment wall thickening with unclear boundaries may be considered as a difference from invasive cholangiocarcinoma. Still, the differentiation would be difficult. As dilation of the obstructed bile duct can have a cystic appearance, sometimes it is necessary to differentiate between cystic form of intraductal papillary neoplasm or MCN. In this patient, the atrophy of the surrounding liver parenchyma and the stones in the cyst may suggest cystic dilation of bile duct rather than cystic neoplasm. Although focal stenosis of the bile duct is frequently seen in patients of BILIN, it is not because of BILIN itself, but because of its underlying disease. Therefore, it would be difficult to discriminate BILIN and inflammatory stenosis on imaging. However, presence of marked stenosis or wall thickening distinguished from surrounding duct may indicate the possibility of malignant transformation. In this case, on MRCP, only focal stenosis and mild proximal duct dilation are observed. On ultrasound and MRI T2-weighted images, Alteration of echogenicity and signal intensity is suspected around stenosis. On surgery, it was confirmed as intraductal carcinoma that had a periductal extension. Mucinous cystic neoplasm is a grossly visible cystic lesion lined by cuboidal or columnar epithelium producing varying amount of mucin. As the presence of ovarian-like stroma is a diagnostic criterion, it occurs almost exclusively in women. Most of the male cases diagnosed in the past are considered as a cystic form of IPMB. MCN is more common in left liver than right and appears as a well-demarcated cyst that does not communicate with the bile duct. MCN commonly shows a multilocular appearance with septation inside and may be accompanied by a small cyst or papillary projection attached to inner wall. It is known that low or intermediate dysplasia is more common than high-grade or invasive form. MCN was also called biliary cystadenoma in the past. Currently, this term is not recommended. This is a case where echogenic material accompanied by hemorrhage was seen on ultrasound. CT shows small cysts and papillary projections on the inner wall. In this case, internal septa were visible on ultrasound but not on CT. Non-enhancing septation, as in this case, is thought to be non-vascularized pseudoseptation. In this case of a low-grade MCN showing an unilocular appearance, differentiation from simple cyst is necessary. MCN is often accompanied by symptoms. The wall is thicker than that of a simple cyst. In addition, mural nodule, septation, upstream duct dilation are more commonly accompanied with MCN. Also, MCN is more commonly seen in the left liver, with smaller number of cysts, less than 3, and are more commonly accompanied with transient hepatic attenuation difference than simple cyst. In this case, that was difficult to differentiate from simple cyst. In initial CT and MRI, an unilocular cyst is seen with upstream duct dilation. 20 months later, the cyst has enlarged in follow-up CT and is accompanied by parenchymal atrophy. An intermediate-grade MCN was diagnosed by surgery. However, upstream duct dilation does not necessarily mean cystic tumors such as MCN. In this case of a simple cyst, upstream duct dilation and parenchymal atrophy were observed. It is difficult to differentiate from MCN. In this lesion showing distinct internal septation and multilocular appearance, the internal septa show the same level of enhancement as the liver. Pathologically, it was diagnosed as low-grade MCN. Enhancing septa can be seen in low-grade MCN. In this case, T2-aided image shows a lobulated cystic mass with a thick wall, which shows no enhancement on post-contrast images. Hemorrhagic material is observed along the inner wall and the surgical specimen. Pathologically, it was diagnosed with low-grade MCN. It is thought that non-enhancing thick wall may not indicate an invasive tumor. This is a case where small cysts are clearly observed along the inner wall. The small cysts show different characteristics from the main cyst on CT, MRI, and ultrasound exam. In this case, the main cyst has high CT attenuation and high T1 signal and low T2 signal, suggesting proteinous material without evidence of hemorrhage. Main cysts show isoecho with liver on the ultrasound, but posterior acoustic enhancement is clearly observed. The existence of mural cysts with different attenuation or signals from the main cyst is characteristic of MCN. However, the presence of small cysts does not suggest malignancy or invasiveness. It should be distinguished from the daughter cyst seen in the high-density cyst. In high-density cyst, in addition to the unique medical history, the internal cyst of the high-density cyst is larger in number, round, and protein. T2-weighted image shows low signal. However, the inner cysts of MCN are usually attached to the inner wall. A cystic mass with internal calcification was found in a 76-year-old woman. On the 1.5-year follow-up CT, it has enlarged and internal cyst was newly presented. In surgery, it was diagnosed with MCN with intermediate grade dysplasia. Although the growth rate of intrahepatic biliary MCN is not well known, in the case of pancreas, it has been reported that MCN shows an average growth rate of 4 mm per year. In a 38-year-old woman, a large invasive MCN was diagnosed. The operation was performed due to severe abdominal distension. Enhancing nodules are well observed in CT and PET. Enhancing mural nodule, intracystic debris, and bile duct dilation have been reported to be more common in invasive carcinoma than in non-invasive MCN. Intraductal papillary mucinous neoplasm of bile duct is characterized by papillary or villous tumor of visible size. It consists of biliary-type epithelium that surrounds the fibrovascular core and often overproduces mucin. Hepatolithiasis or choledochal cyst may be associated, but primary sclerosing cholangitis is less commonly associated with IPMB. It shows favorable prognosis when progressed to colloid carcinoma, but similar prognosis when progressed to usual type of tubular cholangiocarcinoma. IPMB may be also divided into type 1 and 2. Type 1 mainly involves intrahepatic duct and is similar to pancreatic IPMN. Type 2 mainly involves the extrahepatic duct, including hilar duct. It is a tumor with irregular papillary branching or tubular component. IPMB is an interesting disease that can show various imaging patterns. Several authors have suggested different types of imaging findings. Here, we'll explain according to the 5 types of classification method. Imaging patterns of IPMB can be classified into 5 types as follows. First, diffuse duct ectasia or dilation and also intraductal papillary lesion that can be seen on imaging. Second, diffuse duct ectasia but no grossly visible mass. Third, a localized duct dilation or cystic lesion, commonly with mural nodule. Fourth, intraductal cast-like material with minimal duct dilation. Fifth, focal stenotic lesion and proximal dilation. In this first type of IPMB, diffuse duct ectasia and papillary lesions are well observed along the inner wall on imaging. This type is considered to be the most typical form of IPMB that does not need to differentiate with other diseases, and most of them are accompanied by invasive carcinoma. In this slide, along the inner wall of the duct, diffusely scattered papillary regions are well observed on CT, MRI, and MRCP. In endoscopy, villous lesions are identified. In the surgical specimen, mucin and papillary regions are filled in the duct. A mucin plug covering the papillary region is observed on the surgical specimen. Microscopic exam reveals tumor cells showing mucin production and papillary growth. The second type of IPMB also has diffuse duct ectasia due to vigorous mucin production, but grossly visible mass is not identified. It is less common than other types, but mostly shows non-invasive lesion. Although papillary lesions are not visible, correct diagnosis can be suspected when there is duct dilation involving only one segment of a lobe in the absence of stricture or obstructive lesion. Due to Musin plug, untitulated image, curvilinear hypointense striation can be visible. This is called thread sign and can help with the correct diagnosis. In this case of non-invasive IPMB with carcinoma in situ lesion, on CT and MRI, left liver shows more pronounced diffuse asymmetrical dilation and petrous ampulla. EUS shows irregularity of ductal wall and large amount of mucin is observed in ampulla on endoscopy. On cholangiography, the left duct is not well visualized due to the mucin plug. In cholangioscopy, numerous lesions of villi-form lesions are observed. In this case of IPMB with invasive carcinoma diagnosed as 62-year-old woman, there is diffuse duct ectasia. The duct dilation shows asymmetrical dilation, more prominent on the left side. IPMB can be suspected by these findings. In addition, MRI T2-weighted images shows the thread sign that is also helpful for diagnosis. Mucin plug is also seen in the surgical specimen. In the third type of IPMB, localized or cystic duct dilation is seen mostly with mural nodules. It is believed that the connection with the bile duct is minimal or obstructed. It was the most common form of invasive IPMB in a study of our institute. Most cases of this type were accompanied by invasive lesions. In many cases, it is difficult to see communication with the duct on imaging exams. There is no distal duct dilation suggesting mucin discharge. Differentiation from other cystic lesions is necessary. As in this case, in a middle-aged woman whose age overlaps with the age of MCN, when a cystic lesion that does not communicate with bile duct is seen, differentiation from MCN can be difficult. However, a lobulate contour and the presence of mural nodule in a relatively small lesion suggest cystic IPMB. Looking at the differential points between cystic IPMB and MCN, IPMB presents mural nodules in most cases and may be accompanied by distal duct dilation and shows lobulated contour. In contrast, MCN occurs in women, shows round or lobar mass, and is commonly accompanied by internal septa or small cysts. In this case of cystic IPMB with invasive carcinoma, an irregular mural nodule is observed in the cyst of lobulated contour. Mural nodule size of 2.5 cm or more suggests invasive carcinoma. This is a case of cystic IPMB with small size but accompanied with invasive carcinoma. Several mural nodules observed in the mass with wall calcification. Multiple nodules may suggest invasive lesions. According to a study in cases of Severance Hospital and Samsung Seoul Hospital, intraductal mass, human size 2.5 cm or more, multiplicity, ductal wall thickening, and periductal invasion suggest an invasive IPMB. These findings also have been shown to help predict post-surgical outcomes. The fourth form of IPMB shows intraductal cast-like lesion. In this type, duct dilation is minimal and is also often accompanied by invasive carcinoma. As the intraductal tubulopapillary neoplasm, ITPN, that is less frequent than IPMB, also frequently presents this imaging pattern, discrimination is necessary. As duct dilation is not remarkable, differentiation of nodules from intrahepatic stone disease also may be difficult. For the differentiation, it is important to determine whether the intraductal lesions enhance on post-contrast images. In this case, impacted material is observed in the mildly dilated duct, which show higher attenuation on post-contrast CT than on pre-contrast CT, suggesting presence of contrast enhancement in the lesion. On MRI T2-weighted image, intraductal lesion also show higher signal than stone. T1 post-contrast image also shows lesions have contrast enhancement. In the surgical specimen, a cast-like tumor impacted in the bile duct is observed. In this case, unlike the previous case, the CT pre-contrast shows high attenuation material in the bile duct. On post-contrast arterial and portal venous space images, the intraductal lesions do not show contrast enhancement, suggesting partially calcified intraductal stones. Intrahepatic stones are observed in the tissue specimen. The fifth type of IPMB is focal stricture and proximal dilation. Most of them are non-invasive lesions. This is a relatively rare pattern of IPMB and is mainly observed in biliary intraepithelial neoplasia or in simple inflammatory stricture. ITPN is a relatively recently defined lesion, characterized by cuboidal or columnar cells that do not produce mucin, forming tubular architecture. It is a tumor that grows in solid sheet form with little papillary formation. Despite the higher frequency of invasive carcinoma than IPMB, clinical behavior is known to be less aggressive. This is a case of ITPN with focal invasion diagnosed in a 54-year-old male. The lesions that grow into the duct are impacted in the lumen. There is little mucin production, so there is little duct dilation. Intraductal cast-like lesions, as in the fourth pattern of IPMB, are seen with minimal duct dilation. This is a case diagnosed in a 59-year-old woman as ITPN with focally invasive carcinoma. Left IHD showed mild dilation on ultrasound. An obstructive lesion was suspected, but mass was not clearly visible. On CT and MRI images, a polypoid lesion showing mild enhancement is impacted in the left IHD. It was accompanied by mild proximal duct dilation. An intraductal polypoid lesion is identified in the surgical specimen. Until now, the types and imaging findings of the premalignant lesions of cholangiocarcinoma have been reviewed. Imaging examinations help find the premalignant lesions of cholangiocarcinoma and play an important role in differentiation. Bilirubin is mostly found in the form of nonspecific focal stenosis, accompanied by imaging findings of underlying disease. MCN is characterized by presence of internal septa and mural cyst in a cyst showing a smooth outline. IPMB shows various imaging findings, and the frequency of associated invasive carcinoma varies depending on the type. Imaging findings can help diagnose invasive MCN and IPMB and predict the outcomes of IPMB. ITPN is similar to one type of IPMB by showing minimal duct dilation accompanied by intraductal cast-like lesion.